All right, so continue discussion. This is our gentleman, our 56-year-old telecommunications engineer who worked on cell phone towers. Remember, he was in Argentina and he ate on the economy. And he ended up having remember, he came in for pneumonia, received a fluoroquinolone, had symptoms of C. diff, then had a code. The code blue was a short code blue. It was just a PA arrest, had a short recovery. And they started to do the workup. So he's intubated on the ventilator. Wasn't really super sedated, and they noticed when they're doing his liver ultrasound, he had some tenderness when they're looking at it. They also found an abscess. From there, he went to infectious disease, went to IR. In IR, what they did is they did a biopsy. And from that biopsy, he was noted to have Entamoeba histolytica. And this spreads from eating food or water that's been contaminated with feces. He was eating on the economy in Argentina, and he was going to street vendors, and this is how he got sick. Symptoms are cough, fever, chills, almost similar to pneumonia. And that's where we kind of got hooked. We got fish hooked to thinking only he had pneumonia. But what we thought, hey, you have a liver abscess at that point? No. Can have some pain, diarrhea, and jaundice. He did mention he had diarrhea. Wasn't really thinking much about it. We thought it was attributable to pneumonia. He also says that he has been traveling. We figured, he had just a traveler's diarrhea. Here on imaging was noted, and then he went to, as I spoke and said, he went to IR and had his liver aspirated. They went and stuck a needle in the liver, and they pulled it out, and they sent it to the lab. The treatment is metronidazole or tenazidol. And metronidazole, the dose is going to be 500 milligrams to 750 milligrams by mouth 3 times a day for 7 to 10 days. Alternate tenazidol is going to be 2 grams by mouth for 3 days. This is followed by a luminal agent to kind of clear the lumen out of parasites, paramycin or idaquinolone. These paramycin can be given 500 milligrams 3 times a day for 7 days, or idaquinolone 650 milligrams 3 times a day for 20 days. This is kind of to clear out the lumen of parasites. Metronidazole and paramycin should not be given at the same time because diarrhea, a common side effect of paramycin, can make assessing how this patient is doing, if we're doing okay. So this patient, just think about all the things that happened to this patient. They came in, they received fluoroquinolones. The fluoroquinolones have side effects, and the side effect that he received is C. difficile. He recovered from the C. difficile, then he had a code blue. The code blue, more when I come back and I think about it, if I look in retrospective now, many, many years ago, this is one of my first patients I ever had, is I think the C. difficile is we weren't mining his electrolytes. I think his code blue was secondary to hypokalemia from hypomagnesia, from him pooping out all of his magnesium and probably not having his magnesium levels checked. Had a code blue, had the recovery. During the recovery, it noted that he had Entamoeba histolytica, meaning he had a amoebic liver abscess. He had his recovery. We gave him the medications. He did well. We were able to follow up with him as an outpatient, and he did well. All right, here we go. We're going to go clinical scenario, then we're going to go to a board style question, and we'll kind of work through this. This is a real story of a 32-year-old man. He had a sunburn-like rash and tenderness. Now, he wasn't out in the sun. This is kind of in the wintertime, so you can't see sun exposure. He doesn't get radiation exposure from work, and he doesn't use a tanning bed. So sunburn-like rash and tenderness to the right axillary was noted. He had encephalopathy, and he was hypotensive. So there was a rapid deterioration in his patient. So how rapid was it? Is initially meeting him, he was able to answer questions, give consent for a central line. By the time the central line was done, central line was done pretty fast, within 5 to 10 minutes. He was confused and noted to be hypoxic and not breathing well and had to be intubated. While he was being intubated, he was noted for having SVT and then has a code. All right, so what's going on? This is a kind of crazy scenario. This is a young man with really no mass medical history, sunburn-like rash, tenderness right axillary node, and noted to be having a rapid deterioration. All right, let's go through a question. Remember, what are we going to do first? We're going to look at this question stem. Is this question fair? It is not fair because it's a board question. I want you to get used to when I say these will never be fair. I want you to tell yourself that. This is not about the justice system, okay? This is not the halls of justice. This is a question that somebody's asking you so that you get a license in the United States, okay? And they're not going to be fair and get over about your feelings of fairness. Once we get that knocked out, we work and focus on the question. Which of the following is the most appropriate initial management step for this patient? We have a lot of these, don't we? We're talking about management steps. Intravenous fluids, broad-spectrum antibiotics include clindamycin, urgent source control. Well, that sounds reasonable. High-dose corticosteroids alone, there's not too many diseases where we do that, and we'll talk about those. Oral antibiotics and outpatient follow-up, okay. Antiviral therapy and supportive care, okay. Antihistamines and topical steroid. We probably can wipe that one out first, but let's talk about this. Is a 54-year-old man presents to the emergency department with acute onset of fever, hypotension, diffuse erythematous rash. It's kind of like our younger gentleman had, and vomiting. He reports a recent laceration along his leg that becomes painful and swollen. On examination, he is tachycardic hypotensive with evidence of end organ dysfunction, elevated creatinine. What's going to probably happen? Decreased urine output. Remember, we hate that urine output, but that's one of the first signs of kidney dysfunction, even before what? Our creatinine bumps up. And transaminitis, so our liver is taking a hit. This gentleman did not travel to Argentina and eat on economy, so we can't use that. Blood cultures are pending. What are we thinking about? So this rash right here, what are we thinking on this rash? And I want you to get used to this because you're going to see this. And this is not the clinical scenario that you're expecting, because I know what you were taught in your textbooks and taught in your classes. That's why I'm giving you a deviation, the real world deviation. Right here, we're going to give IV fluids and broad spectrum antibiotics, include clindamycin and urgent source control. What does this patient have? He has toxic shock syndrome. You say, well, that is not possible because this is a male. This is a male, and I know that we have changes where people have different genders. This is still a biological male, and you're saying, well, this is not possible. Yes, men can get toxic shock syndrome. Toxic shock syndrome is not only from tampon use, okay? Let's get that out of our system. Just like board questions are not fair, men can get toxic shock syndrome, okay? It is associated with Staph aureus or Streptococcus pyogenes, often involving a skin or soft tissue injury. Aggressive, need to be treated as aggressive fluid support. This is, remember, we discussion and maybe we should use an individual approach instead of the 30 milliliters per kg, but you're going to get fluids, you need broad spectrum antibiotics to include. What do we want to consider as clindamycin? Clindamycin, what is this going to do is preferred to his ability to suppress toxin production and overall outcomes in toxic shock syndrome. So you can look this up and you can see it described in the literature. It's called the eagle effect. And you don't see that term used much anymore, but you can still see it, is using clindamycin to knock out the toxins that can be preformed toxins, can be formed from Staph aureus or Streptococcus pyogenes. Toxic shock syndrome is usually secondary to Staphylococcus aureus or Streptococcus pyogenes. The toxins are superantigens causing stimulation of cytokine production. History of IV drug use, tampon use, burns, or nasal packing, okay? So all these things can be there, but they don't have to be there. In our young man, he happens to be very susceptible to Staphylococcus aureus, very susceptible. Actually, in his case, he was very susceptible to Streptococcus. For whatever reason, and we don't have the technology or the resources for this gentleman, his body is not able to protect himself from strep. And whenever he gets strep, he gets very sick. And this individual, he ended up 32-year-old male, no past medical history, comes in, gets very sick, while putting in central line because he's starting to get hypotensive, then goes into a shock-like state and loses his air, has to be intubated because of the shock-like state, because he becomes altered. Then he gets coded with a short PA arrest. He has recovery. He's very sensitive to Streptococcus pyogenes. Someday in the future, we'll be able to get his genome and figure out why it is, but this is the facts for him now. He's still undergoing testing right now. So bacteremia in 5% of the cases, Streptococcus pyogenes skin infections. So his is strep. It started here in under his arm and his axillary. What happens is it was a follicle, hair follicle, and then it spread. He gets very sick. Remember, he's not a female. All right, strep, toxic shock syndrome. So basically we have to take a look at this. The clinical features are fever, hypotension, diffuse sunburn type rash, that they're not being out in the sun with diarrhea. Treatment is, yes, if it's, we have tampons, remove the tampons, the nasal packing, cleaning the wounds, giving strong antibiotics, including vancomycin plus or minus clindamycin. They may need to get that sick as may need immunoglobulin, IVIG. That is controversial, but there's a discussion with it. Complication can be ARDS. This gentleman had DIC, multi-system organ failure, which our young gentleman had. So let's go through and just kind of go through our algorithm. If it's streptococci, local invasive strep infection, his happened to be in the armpit. There was an abscess there that was able to remove with the surgical team that helped him get better. And staphylococcal, if there's menstruating female and they have tampons, removing the tampon, removing source control, non-menstruating, wound infections, skin and soft tissue infection, impacted infections. Now I had a young lady who happened to have toxic shock syndrome. Remember, it's not only limited to females. In this young lady is she had staphylococcal. Her source was a toe. One of her toes, she stubbed her toes, wasn't really taking care of herself, had prediabetes, and that toe was her source of infection. Once we removed that source of infection, she got much better. Toxic shock syndrome treatment, adequate resuscitation as we discussed, and to maintain tissue perfusion, source control, surgical debridement. Droplet precautions till antibiotics have been given for 24 hours. Contact precautions in those with draining wounds. Empiric antibiotics, vancomycin, meropenem or piperacillin tazobactam. Remember, meropenem, we're going to kind of go through side effects when we're talking about ID. Meropenem can do what? Lower seizure threshold. Meropenem, all the carbapenems can lower seizure threshold. Pyrogenase is going to be penicillin plus clindamycin. MRSA, vancomycin plus clindamycin. MSSA, remember, we need to, if we figure out, as soon as we figure out MSSA, we need to get rid of the vancomycin. Increase morbidity with vancomycin. And you need to go to nafcillin or oxacillin plus the clindamycin. And you may run across some ID doctors that do not like clindamycin. We're discussing it here. This is part of the ID Rex, but there are some people that are not going to like clindamycin. They're going to feel it has a greater risk for C. diff, and they're correct. Prophylaxis for invasive group A strep for family members exposed in older adults with comorbidities, immunocompromised, or drug use. So may need to consider if the patient has group A strep, do these family members, that's why we have the droplet right away, do they need to be protected too? All right. And then benzathioine, penicillin G plus rifampicin for them, or clindamycin or azithromycin. So this would be a question of what we give for them. All right, let's talk about the Group A Streptococcus GAS toxic shock syndrome. The diagnostic criteria for Group A Streptococcus toxic shock syndrome encompasses hypotension along with evidence of involvement in multiple organ systems, characterized by at least two of the following: renal impairment, it's an AKI, coagulopathy, hepatic dysfunction, so you're going to have elevated transaminase, an acute respiratory distress syndrome, need an isolation of the Group A Streptococcus, and a confirmation case meets all the criteria plus isolation of Group A Streptococcus at a normal sterile site. All right, and lack of identification of an alternative etiology. Generalized erythematous rash, which may include desquamization, which is going to be flaking of the skin. Just think about it as you rub it, the skin's going to flake off very easily. Soft tissue necrosis, concurrent necrotizing fasciitis. Streptococcus toxic shock syndrome is going to be supportive care treatment. Initiate antibiotic regimen should include both penicillin G, 2 to 4 million units every IV every 4 to 6 hours. Clindamycin 600 to 900 milligrams IV every 8 hours. Addition of clindamycin may be associated with increased survival in patients with GS and necrotizing fasciitis and toxic shock syndrome, but is not clearly demonstrated for those with toxic shock syndrome alone. For patients with penicillin allergy, substitute vancomycin, linezolid. Remember linezolid, what's our concern for side effect with that is serotonin syndrome. Also has myelosuppression. Daptomycin, where does daptomycin not work? It doesn't work in the lungs. It's denatured by surfactant. IVIG can be considered as an adjunct therapy, but supportive data is very limited. It's mixed and limited. But here again, these are sick patients. They can be younger, and we want to get them through this. Staphylococcal toxic shock syndrome. The CDC criteria for diagnosis of staphylococcal toxic shock syndrome consists of fever at least 102 degrees Fahrenheit, which is 38.9 degrees Celsius, widespread macular erythematous rash, peeling of the skin occurring with 1 to 2 weeks following the rash's appearance, hypotension, involvement of 3 or more organ systems. You can have GI with vomiting, nausea, and diarrhea. Musculoskeletal can be severe myalgias or creatinine kinase levels greater than equal to 2 of normal. Renal creatinine or blood BUN greater than equal to 2 times normal or sterile pyuria. Hepatic transaminitis or total bilirubin greater than equal than 2 times normal. Platelet count less than 100,000. Neurological can be altered mental status in the absence of focal neurological symptoms, meaning you're not having a stroke. And you can have hyperemia, meaning inflammation of the mucosal membranes, the oropharyngeal or conjunctival or vaginal. Continued discussion on Staphylococcus toxic shock syndrome. Vancomycin 15 to 20 milligrams per kilogram, IV every 8 to 12 hours for adults with normal renal function. Clindamycin 600, 900 milligrams IV every 8 hours in an adult. Now we talked about the eagle effect because clindamycin inhibits bacterial protein synthesis, which prevents the production of penicillin-binding protein, named after hairy eagle. So you can look that up. And I would like to talk to you quickly about vancomycin. Vancomycin, if your system allows you to, get the pharmacy to dose it. You cannot be in the hospital 24/7 for months at a time or for how long this patient's going to be there. They will have changes in their renal function, and these need to be adjusted by a team that's going to be able to follow them. If you have a great team and you can do it, and you have, but now there's such great algorithms, and there's even AI modules to help make sure that vancomycin is properly diagnosed. These AI modules are excellent. They use a specific algorithm, and they can do random vancomycin draws, and they can adjust these medications and keep these patients in a good therapeutic range. This is the young lady. This was a young lady who lost part of her toe. So she originally, see this toe right here, she stubbed this toe. Let's get a nice little drawing of the toe. Look at that. We stubbed this toe. We had a little bit of a fracture back here, and she was very sick. She had toxic shock syndrome. She ended up being on 5 pressors at one time. She also got necrosis right here. You can see she also had, that toe had a fracture in it. This toe had to be removed. She had bad blood flow while she was on the 5 pressors. Pressors can cause damage. That's why we have to have license to do them. That's why you can't just do them on the streets. They can cause damage. She lost her toe, but she's alive with a lost toe, and she was very happy to be alive. All right, let's go to the next case. This is a 37-year-old male with rash on his body, swollen lymph nodes, malaise, fever, sore throat. About 6 weeks ago, he had an ulcer, and it was painless on his penis. Okay? Penis in his penis, okay? And then we saw this rash. What do we got here? I know this kind of is hard to see, but what is that? You can see it down here too. Right here. This is syphilis. This gentleman had syphilis. And syphilis is making a comeback, and we need to be aware of it. We need to be able to recognize it because it's making a comeback. Painless ulcer chancre at the site of inoculation with the troponium palladium and begins with a papillary lesion and then ulcerates with a clean wound bed. You can have regional lymphadenopathy, which can be common. The chancre normally heals within 3 to 6 weeks. They think they're good. They're like, I don't know what that was. I think I'm good. Let's go back to get back on the front lines.